I want you to do something right now. Sit back in your chair. Extend both of your legs in front of you and look at them carefully. Look at the skin on your lower legs and ankles. Look at the color. Look at the texture. Notice whether one leg appears slightly fuller than the other. Notice whether your ankle bones are clearly visible or whether the skin around them appears puffy and indistinct. Run your finger along your shin bone and press gently into the skin just above your ankle. Hold that pressure for 5 full seconds. Then release. Does the skin spring back immediately, or does it leave a small depression, a dent, that takes several seconds to fill back in? Now notice something else. When you walk across a room, is there a heaviness in your legs that was not there 5 years ago? A fatigue in the calves that arrives sooner than it used to? Perhaps a cramping sensation that wakes you from sleep in the night? Or a subtle aching discomfort that seems to worsen as the day progresses and improves somewhat when you elevate your feet? If any of these observations resonated with you, if you recognized even one of these signs in your own body, I need you to understand something with complete clarity. These are not the inevitable inconveniences of growing older. They are not simply the result of being on your feet too long or eating too much salt at dinner. They are the potential surface expressions of a serious and progressive vascular condition that affects an estimated 18 million Americans over the age of 55, the majority of whom have never received a diagnosis, have never been specifically screened, and have been quietly living with a condition that is simultaneously damaging their cardiovascular system, their kidney function, their wound healing capacity, and in its most advanced stages, threatening the viability of the limb itself. And the most alarming dimension of this conversation is not the condition itself. It is the fact that the warning signs have been present, visible, palpable, and clinically significant for years before the diagnosis is made. Years during which intervention could have been initiated, progression could have been slowed, and the cascade of downstream complications could have been meaningfully prevented. Hello everyone, I am Dr. Kaur, and welcome back to Dr. Kaur Health. What we are going to cover today is one of the most underdiagnosed and underdiscussed vascular conditions in the American senior population. A condition whose early warning signs appear in the legs years before the serious complications emerge, and whose warning signs are frequently dismissed, minimized, or misattributed to other causes by patients and clinicians alike. This channel exists to give you the complete, honest, clinical picture that the time constraints of modern medicine so often prevent your physician from delivering. If you are new here, subscribe now and turn on notifications, because the information in today's video is directly relevant to tens of millions of Americans, and recognizing these warning signs early may be one of the most important health decisions you ever make. To fully understand what the warning signs in your legs are telling you, we need to begin with a clear picture of the vascular architecture of the lower extremity and what happens to that architecture as the decades pass. Your legs are supplied by two distinct and fundamentally different vascular systems operating simultaneously and in continuous coordination. The first is the arterial system. Oxygenated blood leaves the heart through the aorta, travels down through the iliac arteries into the femoral artery in the thigh, then branches into the popliteal artery behind the knee, and finally divides into the tibial and peroneal arteries that supply the lower leg, ankle, and foot. This system operates under high pressure, driven by the mechanical force of each cardiac contraction, and its primary function is oxygen and nutrient delivery to every cell in the lower extremity. The second is the venous system. Once the arterial blood has delivered its oxygen and nutrients to the tissues, the deoxygenated blood must make the return journey back to the heart and lungs for reoxygenation. This return journey is a remarkable physiological feat because it requires moving blood upward against the constant downward pull of gravity through a low-pressure system that lacks the driving force of the heart's contractile power. The venous system accomplishes this feat through two primary mechanisms. The first is a series of one-way valves distributed throughout the veins of the lower leg and thigh. These valves open to allow blood to move upward toward the heart and close to prevent it from falling back down under gravity. They are delicate, precisely engineered structures that perform this function hundreds of thousands of times over the course of a lifetime. The second mechanism is the muscular venous pump, the contraction of the calf muscles during walking and movement, which physically squeezes the deep veins of the lower leg and propels blood upward past each successive valve toward the heart. Now consider what happens to both of these systems over the course of 5, 6, or 7 decades of life. In the arterial system, the same process of atherosclerosis, the accumulation of inflammatory plaque within the arterial walls that threatens the coronary arteries supplying the heart, is simultaneously occurring in the peripheral arteries supplying the legs. In the peripheral circulation, this process is called peripheral artery disease, or PAD, and its progression follows the same fundamental mechanism as coronary artery disease. Endothelial dysfunction, lipid infiltration, foam cell formation, plaque accumulation, arterial narrowing, and ultimately critical reduction in blood flow to the tissues of the lower extremity. In the venous system, decades of gravitational stress, prolonged standing or sitting, pregnancy in women, and the gradual deterioration of connective tissue integrity cause the one-way valves within the veins to become incompetent, to lose their ability to close completely and prevent backflow. When venous valves fail, blood pools in the lower legs under the influence of gravity. The veins dilate and become tortuous. Pressure builds within the venous system, and this elevated venous pressure begins to force fluid, plasma, out of the capillaries and into the surrounding tissues of the lower leg and ankle. The result is edema, swelling, the puffy, heavy, uncomfortable lower legs that so many Americans over 55 have come to accept as simply part of getting older. It is not simply part of getting older. It is a pathological process with identifiable causes, progressive consequences, and effective interventions when it is recognized early enough to matter. Let me now walk you through the 8 warning signs that appear in the legs and lower extremities. Signs that collectively represent some of the most important and most frequently overlooked clinical information available to you about the state of your vascular health. Warning sign. Number 1. Pitting edema. This is the sign I described at the beginning of this video. When you press your finger firmly into the skin over the lower shin or just above the ankle and hold for 5 seconds, the normal response is immediate skin recoil. The tissue springs back without leaving any impression. In pitting edema, the accumulated fluid in the subcutaneous tissue is displaced by the pressure of your finger and does not immediately return. The indentation, the pit, remains visible for several seconds to several minutes after the pressure is released. The depth and persistence of the pit correlates roughly with the severity of the fluid accumulation. Mild pitting edema, grade 1, produces a shallow pit of 2 millimeters or less that rebounds within 15 seconds. Grade 4, pitting edema, the most severe classification, produces a deep pit of 8 millimeters or more that may persist for 2 minutes or longer and is associated with significant visible distortion of the limb's normal contour. The critical distinction that everyone over 55 must understand is the difference between bilateral symmetric edema and unilateral edema, swelling in both legs equally versus swelling predominantly or exclusively in one leg. Bilateral symmetric pitting edema is most commonly caused by systemic conditions: heart failure, kidney disease, liver disease, low albumin, venous insufficiency, or medication side effects. It reflects a global disturbance in fluid balance or venous return. Unilateral pitting edema, one leg significantly more swollen than the other, is a red flag for a different and potentially more immediately dangerous cause: deep vein thrombosis, a blood clot forming within the deep veins of the leg. And the clinical implications of unilateral leg swelling are urgent enough that they warrant same-day medical evaluation in most clinical contexts. Warning. Sign number 2. Skin color changes. The skin of the lower legs and ankles is one of the most sensitive indicators of the quality of blood flow, both arterial and venous, in the lower extremity. In chronic venous insufficiency, the chronically elevated venous pressure and the persistent accumulation of fluid in the subcutaneous tissue eventually begins to damage the capillaries themselves. Red blood cells leak out of the damaged capillaries and into the surrounding tissue, where they break down and release hemosiderin, an iron-containing pigment, into the skin. The result is a characteristic brownish, rust-colored staining of the skin on the lower legs and ankles, called hemosiderin deposition or lipodermatosclerosis in its more advanced form. This pigmentation does not wash off. It does not fade with rest or elevation. It represents permanent structural change in the skin, driven by chronic venous hypertension. In peripheral artery disease, the skin changes reflect the opposite problem: insufficient arterial supply rather than venous congestion. The skin becomes pale, thin, and shiny. The leg may appear dusky or mottled, an irregular blotchy pattern of pale and purplish discoloration, particularly when the leg is elevated. When the leg is allowed to hang down, a dependent rubor, a deep reddish-purple flushing, may appear as gravity assists whatever limited arterial flow remains in delivering blood to the ischemic tissues. Both patterns of skin color change are clinically significant. Both deserve medical evaluation, and both are warning signs that are routinely dismissed by patients and sometimes by clinicians as cosmetic issues or normal aging changes. They are neither. Warning sign. Number 3. Leg hair loss. This is one of the most specific and most consistently overlooked warning signs of peripheral artery disease in the lower extremity. The hair follicles of the lower leg and foot are among the most metabolically demanding structures in the skin. They require a continuous and adequate supply of oxygenated blood to sustain their growth cycles. When arterial blood flow to the lower leg is chronically reduced, as occurs in peripheral artery disease, the hair follicles are among the first structures to demonstrate the effects of ischemia. The result is a progressive loss of hair on the lower legs, ankles, and tops of the feet, bilaterally in most cases of systemic peripheral artery disease. The skin in these areas becomes smooth, hairless, and often waxy in texture. This sign is so specific to arterial insufficiency that its presence in the clinical examination of a patient over 55 is considered a meaningful indicator prompting further vascular assessment. Most patients who exhibit this finding have never connected it to their vascular health. They notice that their legs have become less hairy over the years and attribute it to aging, which in a narrow sense is accurate. It is a consequence of the arterial aging process. But it is not an inevitable or benign manifestation of that process. It is a warning. Warning sign. Number 4. Claudication. Claudication is the clinical term for the specific pattern of leg pain that is the hallmark symptom of peripheral artery disease in its earlier symptomatic stages. The word derives from the Latin claudicare, to limp, and the clinical picture it describes is precise and distinctive. The individual begins walking. After a consistent and reproducible distance, perhaps 1 block, perhaps 2, perhaps less, a cramping, aching, or fatiguing pain develops in the calf muscles, or sometimes in the thigh or buttock depending on the location of the arterial narrowing. The pain is not present at rest. It begins with exertion, worsens with continued walking, and forces the individual to stop. Upon resting for 1 to 5 minutes, the pain completely resolves, and when walking is resumed, it returns again at approximately the same distance. This pattern, exertional pain with consistent onset distance, complete relief with rest, and reproducible recurrence, is the clinical fingerprint of claudication. It reflects the inability of the narrowed arteries to increase blood flow sufficiently to meet the metabolic demands of the exercising muscles. The danger of claudication as a warning sign is that it is so easy to accommodate. The individual simply stops walking as far. They take the elevator instead of the stairs. They park closer to the entrance. They gradually, imperceptibly, restructure their daily activity around the limitations of their deteriorating arterial supply. And in doing so, they mask the progression of the disease from both themselves and their physician. By the time they seek medical attention, the peripheral artery disease may have advanced considerably beyond the stage at which the claudication first appeared. Warning. Sign number 5. Rest pain. Rest pain represents a critical and alarming progression beyond claudication. It signals that arterial blood flow to the lower extremity is now so severely compromised that it is insufficient even to meet the metabolic demands of the tissues at rest, not just during exercise. Rest pain in peripheral artery disease characteristically occurs in the foot and toes, the most distal and therefore most vulnerable tissues in the lower extremity. It typically begins at night, when the individual is lying flat in bed and the assistance of gravity in delivering blood to the foot is lost. The pain is severe, burning, and persistent. It is frequently partially relieved by hanging the foot off the edge of the bed or by getting up and walking briefly, both positions that use gravity to augment the diminished arterial supply. The presence of rest pain in the setting of peripheral artery disease defines a clinical stage called chronic limb-threatening ischemia. This is no longer a condition that can be managed with lifestyle modification and risk factor control alone. It requires urgent vascular surgical evaluation because the next stage in this progression is tissue death, gangrene, and potential limb loss. Warning sign. Number 6. Non-healing wounds. The tissues of the lower leg and foot in patients with advanced peripheral artery disease or severe chronic venous insufficiency lose their capacity for normal wound healing. The physiological processes of tissue repair, cellular proliferation, collagen synthesis, angiogenesis, all require adequate oxygen delivery and effective removal of metabolic waste products. Both are impaired when arterial supply is diminished or venous pressure is chronically elevated. A minor scratch, a blister from a shoe, a small cut from a toenail, an insect bite. In a healthy vascular system, these trivial injuries heal within days without complication. In a leg with compromised vascular supply, these same minor injuries can evolve into chronic non-healing ulcers that persist for weeks, months, or in extreme cases, years. The wound remains open, fails to granulate, becomes susceptible to infection, and in the context of severe arterial insufficiency or concurrent diabetes, can progress to deep tissue infection, osteomyelitis, bone infection, and ultimately the need for amputation. The American Diabetes Association estimates that more than 50% of all non-traumatic lower extremity amputations in the United States occur in individuals with diabetes, and the majority of those amputations are preceded by a non-healing wound that received inadequate attention in its early stages. Every non-healing wound on the lower leg or foot in an adult over 55 deserves prompt medical evaluation, without exception. Warning sign. Number 7. Temperature asymmetry. Place the back of your hand against the skin of your lower leg and foot. Now compare the temperature of both feet side by side. In normal vascular function, both feet should feel approximately the same temperature. The feet may be cool relative to the rest of the body. This is normal. But they should be symmetrically cool. A foot or lower leg that is consistently and noticeably cooler than its counterpart is a warning sign of reduced arterial blood flow to that extremity. The tissues are receiving less warm oxygenated blood than the opposite side, and the skin surface temperature reflects this deficit. Conversely, a lower leg that feels warmer than normal, particularly in the context of redness, swelling, and tenderness, may reflect the inflammatory response associated with an acute deep vein thrombosis or a skin and soft tissue infection called cellulitis, both of which require urgent medical attention. Temperature asymmetry between the two lower extremities is a simple, cost-free clinical observation that anyone can make, and it is a meaningful warning sign that is almost never taught to patients as part of their routine self-monitoring practice. Warning. Sign number 8. Visible varicose veins with associated symptoms. Varicose veins, the dilated, tortuous, rope-like veins that appear beneath the skin surface of the legs, are extraordinarily common in the population over 55, affecting an estimated 30 to 40% of adults, and they are so common that they are almost universally dismissed as a cosmetic nuisance. But varicose veins are not merely cosmetic. They are the visible surface manifestation of chronic venous insufficiency, the failure of the venous valve system to maintain effective one-way blood flow from the leg back toward the heart. And when varicose veins are accompanied by specific symptoms, a persistent aching, heaviness, or fatigue in the leg that worsens with prolonged standing and improves with elevation, itching or burning sensations over the varicosities themselves, recurring episodes of superficial thrombophlebitis, inflammation and clotting within the varicose vein itself, or the skin changes described earlier. They are no longer a cosmetic issue. They are a vascular condition requiring clinical evaluation and management. The 8 warning signs I have just described are not random or unrelated phenomena. They are the surface expressions of a relatively small number of underlying vascular conditions that exist on a spectrum from manageable and reversible in their early stages to limb-threatening and life-threatening in their advanced stages. Let me walk you through the 3 primary conditions that account for the majority of these warning signs in the population over 55. Condition 1. Peripheral artery disease. Peripheral artery disease, PAD, is the systemic manifestation of atherosclerosis in the arteries of the lower extremities. It shares the same fundamental pathological mechanism as coronary artery disease and carotid artery disease: endothelial dysfunction, lipid infiltration, chronic inflammation, plaque formation, and progressive arterial narrowing. The prevalence of peripheral artery disease increases dramatically with age. It affects approximately 12% of adults between the ages of 55 and 64, rising to approximately 23% of adults over the age of 80. It is more prevalent in individuals with diabetes, hypertension, hyperlipidemia, a history of smoking, or a family history of cardiovascular disease. The same risk factor profile as coronary artery disease. And this is the critical clinical relationship that makes peripheral artery disease so much more than a leg problem. The presence of peripheral artery disease is one of the most powerful predictors of concurrent coronary artery disease and cerebrovascular disease, disease of the blood vessels supplying the heart and the brain. Individuals diagnosed with peripheral artery disease have a 2 to 6 times higher risk of myocardial infarction and a 2 to 3 times higher risk of stroke compared to age-matched individuals without peripheral vascular disease. Peripheral artery disease is not just a condition of the legs. It is a systemic vascular disease, and the legs are the window through which it announces its presence, often years before the patient has any cardiac or neurological event. The standard diagnostic tool for peripheral artery disease is a simple, non-invasive measurement called the ankle brachial index, or ABI. It compares the blood pressure measured at the ankle to the blood pressure measured at the brachial artery in the upper arm using a standard blood pressure cuff and a handheld Doppler device. In a normal vascular system, the ankle pressure should be equal to or slightly higher than the arm pressure, an ABI of 1.0 to 1.4. An ABI below 0.9 indicates peripheral artery disease. An ABI below 0.4 indicates severe ischemia, consistent with critical limb-threatening ischemia. This test is inexpensive, takes approximately 15 minutes to perform, and requires no specialized imaging equipment. Yet it remains dramatically underutilized in the routine care of patients over 55 with risk factors for vascular disease. Condition 2. Chronic venous insufficiency. Chronic venous insufficiency, CVII, is the most common vascular disorder of the lower extremity in the adult population. It results from the progressive failure of the venous valve system and the muscular venous pump to maintain effective upward blood flow from the leg toward the heart. The consequences of chronic venous insufficiency are driven by the sustained elevation of venous pressure in the lower leg. This chronically elevated pressure forces fluid into the surrounding tissues, producing edema. It damages the capillary walls, producing skin staining and inflammation. It creates a hostile biochemical environment in the skin that impairs wound healing and predisposes to venous ulceration, the most common form of chronic leg ulcer in the adult population. Venous ulcers typically appear on the medial lower leg, the inner aspect of the ankle, in an area historically called the gator zone. They are shallow, irregularly bordered wounds with a moist fibrinous base, surrounded by the characteristic hemosiderin-stained and often indurated skin of lipodermatosclerosis. They are notoriously difficult to heal, frequently recur after successful treatment, and represent a significant source of pain, functional limitation, and reduced quality of life for affected individuals. The treatment of chronic venous insufficiency has advanced significantly over the past decade. Compression therapy, graduated compression stockings or bandaging that applies graded pressure to the lower leg, mechanically counteracting the elevated venous pressure, remains the cornerstone of conservative management. Minimally invasive endovenous procedures, laser ablation, radiofrequency ablation, and chemical sclerotherapy can effectively eliminate the incompetent venous segments responsible for the reflux, with high success rates and rapid recovery. But all of these interventions are most effective and most likely to prevent the advanced complications of venous ulceration and skin damage when initiated early, before irreversible structural changes in the skin and subcutaneous tissue have accumulated. Condition 3. Deep vein thrombosis. Deep vein thrombosis, DVT, is the formation of a blood clot within the deep venous system of the lower extremity, most commonly in the calf veins, the popliteal vein behind the knee, or the femoral and iliac veins of the thigh. The clinical significance of deep vein thrombosis is twofold, and both dimensions are serious. The first is the local consequence. The clot obstructs venous return from the affected leg, producing the characteristic unilateral swelling, warmth, redness, and pain that represent the classic presentation of acute DVT. The second, and far more immediately life-threatening consequence, is pulmonary embolism, the detachment of a portion of the clot from the venous wall, its travel through the venous circulation into the right heart, and its lodgement in the pulmonary arteries supplying the lungs. Large pulmonary emboli can cause massive hemodynamic collapse and sudden death. Smaller emboli produce varying degrees of respiratory compromise, chest pain, oxygen desaturation, and right heart strain. Deep vein thrombosis and pulmonary embolism together constitute venous thromboembolism, a condition that causes an estimated 100,000 deaths annually in the United States, making it the third leading cause of cardiovascular mortality after heart attack and stroke. The risk of venous thromboembolism increases progressively with age, with the incidence approximately doubling for each decade of life after 40. Additional risk factors include prolonged immobility, recent surgery or hospitalization, active malignancy, inherited clotting disorders, hormone therapy, obesity, and a prior history of DVT or pulmonary embolism. Unilateral leg swelling, particularly when accompanied by calf tenderness, warmth, and redness, in an adult over 55 should be considered deep vein thrombosis until proven otherwise. This is not a symptom to monitor at home with rest and elevation. It is a symptom that warrants same-day medical evaluation and ultrasound imaging of the deep venous system. Understanding the warning signs and the conditions they represent is essential. But equally essential is understanding which risk factors for these conditions lie within your direct control, and what specific interventions the evidence most strongly supports. Smoking remains the single most powerful modifiable risk factor for peripheral artery disease. The risk of PAD in current smokers is 2 to 4 times higher than in non-smokers, and the relationship is dose-dependent. The more pack years of smoking history, the greater the risk, and the more rapidly the disease progresses. Smoking cessation at any age produces measurable benefit. The vascular benefits of cessation begin within weeks and continue to accumulate for years after the final cigarette. Diabetes and blood sugar control represent the second most critical modifiable risk factor. Hyperglycemia, chronically elevated blood sugar, damages the endothelium through multiple mechanisms simultaneously. It increases oxidative stress, promotes advanced glycation end product formation, and impairs nitric oxide synthesis, creating an internal vascular environment that accelerates both arterial and microvascular disease. Optimal glycemic control, achieving and maintaining an HbA1c at or near the target established by your physician, reduces the risk of peripheral vascular complications measurably. Hypertension drives vascular disease through the mechanical stress of elevated pressure on already vulnerable arterial walls. The same blood pressure management strategies we discussed in our previous video are directly relevant to the health of the peripheral vasculature, and achieving target blood pressure control reduces the rate of progression of peripheral artery disease. Physical activity exerts its protective effects on both the arterial and venous systems through multiple pathways. In the arterial system, regular walking and moderate aerobic exercise stimulate the development of collateral circulation, the growth of new small blood vessels that provide alternative pathways for blood flow around arterial blockages. In the venous system, the muscular venous pump of the calf muscles is activated only during movement, making regular ambulation the single most effective intervention for reducing venous hypertension and its downstream consequences. For individuals with claudication, a supervised exercise program, specifically a structured walking program that repeatedly takes the patient to the threshold of claudication pain and then allows recovery, has been shown in multiple randomized controlled trials to improve walking distance, functional capacity, and quality of life to a degree comparable to pharmacological or interventional treatment in many patients. Leg elevation is a simple, cost-free intervention with genuine clinical benefit for individuals with chronic venous insufficiency. Elevating the legs above the level of the heart for 30 to 60 minutes twice daily uses gravity to assist venous return, reduces hydrostatic pressure in the lower leg veins, and allows accumulated edema fluid to be reabsorbed into the circulation. It is not a cure for venous insufficiency, but it is a meaningful adjunct to compression therapy and the most practical thing an individual can do daily to reduce the symptomatic burden of venous disease. Weight management reduces the mechanical burden on the venous system. Excess body weight increases intra-abdominal pressure, which directly impairs venous return from the lower extremities and accelerates the deterioration of venous valve function. One of the most consistent and most frustrating patterns in the management of peripheral vascular disease is the gap between when symptoms first appear and when a patient first presents those symptoms to their physician for evaluation. Studies examining the natural history of peripheral artery disease consistently document an average delay of 2 to 3 years between the first appearance of claudication symptoms and the first clinical evaluation for peripheral vascular disease. 2 to 3 years during which the disease is progressing, during which the collateral circulation that might have developed with appropriate supervised exercise is not being maximized, during which cardiovascular risk factor modification that might slow atherosclerotic progression is not being optimized, during which the window of opportunity for the most effective interventions is narrowing. This delay happens for identifiable and understandable reasons. Claudication pain resolves with rest. Mild edema is easy to attribute to a long day on the feet. Skin color changes are dismissed as cosmetic. Hair loss on the legs is attributed to aging. And at every physician appointment, the primary agenda, reviewing blood pressure, cholesterol, blood sugar, and current medications, leaves minimal time for a comprehensive conversation about leg symptoms that the patient may not think to volunteer. You can close this gap by being specific and proactive in your communication with your physician. Tell your doctor, "I have noticed that my legs feel heavy and swollen by the end of the day, particularly around the ankles. I have noticed that the swelling is worse when I have been sitting for long periods and better when I elevate my feet." Tell your doctor, "I have noticed that when I walk more than a block or two, I develop a cramping discomfort in my calves that forces me to stop. It goes away within a few minutes of rest, but it comes back at about the same distance when I start walking again." Tell your doctor, "I have noticed a brownish discoloration on the skin of my lower legs that has been gradually developing over the past year or two." Tell your doctor, "I have noticed that the hair on my lower legs seems much thinner than it used to be, and the skin looks shiny and different in texture." Tell your doctor, one of my legs has been more swollen than the other for the past several days, and it feels tender and warm. These specific, descriptive, symptom-focused communications give your physician the clinical information necessary to initiate the appropriate evaluation: an ankle brachial index measurement, a venous duplex ultrasound, a lower extremity arterial duplex. Rather than leaving the symptoms unaddressed in the context of a time-limited appointment focused on other agenda items. You are the most important observer of your own body, and the information you communicate, specifically, accurately, and proactively, is the foundation of effective early diagnosis. I want to give you a concrete, practical, daily self-monitoring protocol that anyone over 55 can implement immediately, requiring no equipment, no expense, and no more than 5 minutes of daily attention. Every morning, before getting dressed, sit on the edge of your bed and perform the following observations. First, look at both feet and lower legs side by side. Are they approximately the same size and shape? Are there any new areas of redness, bruising, or skin breakdown that were not present the previous day? Second, perform the pitting edema test I described at the beginning of this video. Press your finger firmly into the skin above the ankle bone for 5 full seconds. Release. Does the skin spring back immediately on both sides? Or is there residual pitting on one or both sides? Third, assess the temperature of both feet by placing the back of your hand against the skin of the lower leg and foot on each side. Are they approximately the same temperature, or is one noticeably cooler than the other? Fourth, assess skin color. Is there any new pallor, mottling, or dusky discoloration that was not present previously? Fifth, when you take your first steps of the morning, notice whether there is any pain, cramping, or unusual discomfort in the feet or calves with weight bearing. This 5-point daily assessment takes less than 3 minutes. It requires no equipment, and it creates a continuous longitudinal record of your lower extremity vascular status, a record that can detect meaningful changes early, before those changes have progressed to the point where intervention becomes dramatically more complex and the outcomes dramatically less favorable. Document what you observe. A simple notebook works. A smartphone note works. The specific details, which leg, which area, what the skin looks like, whether the pitting is present and how deep, are the clinical data that will be most useful to your physician when you communicate your concerns. The legs speak. They speak in the language of swelling and skin color and temperature and pain patterns, and the texture of the skin above the ankle and the presence or absence of hair on the lower shin. They have been speaking, quietly, persistently, in the precise clinical vocabulary of vascular disease, in the bodies of millions of Americans over 55 for years before the diagnosis is finally made. The reason those warnings go unheard is not a failure of the body to communicate. It is a failure of the educational system around aging to teach people what to listen for. You now know what to listen for. You know the 8 warning signs. You know what conditions they represent. You know the risk factors within your control. You know how to communicate your observations to your physician in a way that prompts the appropriate evaluation. And you have a daily self-monitoring protocol that takes 3 minutes and costs nothing. The peripheral vascular system is not separate from your heart health or your brain health or your kidney health. It is the same systemic vascular disease expressed in a different anatomical location. And the legs, precisely because their warning signs are visible and palpable in a way that the coronary arteries and the carotid arteries are not, offer you a remarkable and underutilized opportunity for early detection. Use that opportunity. Look at your legs. Listen to what they are telling you, and bring that information to your physician with the specificity and the urgency it deserves. I am Dr. Kaur. Thank you for spending this time with me today. If this video added clarity and value to your understanding of your own vascular health, please share it with someone you care about who is over 55. The warning signs we discussed today may already be present in people you love, people who have never been told what those signs mean. Subscribe to Dr. Kaur Health for weekly evidence-based senior health education, and I will see you in the next one.